Hi, good evening. This is one of our midweek discussions with Dr. Chetty, looking at diagnosis of COVID. And you have to understand this is going to be a clinical discussion because we are trying to understand what happens with regards to severe disease. So I'm not talking about somebody just having minor symptoms and so on. I'm talking about patients who get really sick, end up in hospital. How do we diagnose them? That's really the question that I think is very important at this point. So, before I start, I just wanted to mention that in the links usually below is the ability to join our newsletter as well. Coming up next week is going to be on the Thursday of next week is going to be presenting Storm. This is the spike triggered autoimmune response. And this is a specific area that I think is very important as to how the disease is going to present in the near future. That's a separate clinical discussion. But for the time being, without any further ado, let's just make sure that we have got Dr. Shetty with us. Shankara, how are you?
Hi, Philip. I'm fine. I'm fine.
Excellent,
And,
excellent.
and
So
welcome to all our viewers tonight.
yes, yes, yes. So let's get into it, and let me explain what I'm trying to see if I can get my head around. At the moment, or let me put it to you, the question that I often ask people is the diagnosis of COVID, and I'm thinking of more severe disease, is the diagnosis of COVID a clinical diagnosis or is it a lab diagnosis?
I think at the moment, Philip, with the unreliable PCR test, it is more a clinical diagnosis. Uh, until we find better methodologies for testing and more efficient testing, and testing that's simpler, you don't have to go to a lab. Uh, I think at this point in time, it is a clinical diagnosis.
No, that's a problem because at the moment, certainly when we look at first world countries, the PCR test, they will consider it still to be 90% effective, as opposed to, say, a lateral flow test. Now, I can't imagine that the same tests that we have been using over the pandemic as more and more variants come out is still going to be as efficient. It may still pick up some cases, but based on my observation, it tends to be quite hit and miss. And so,
Yeah.
therefore, how, from a clinical perspective, do we diagnose COVID? So, based on just your experience, Shankara, imagine you didn't have a PCR test. What would make you think that this patient has COVID?
Philip, there's many little nuances that I think clinicians need to pick up on. If you look at the first initial viral phase of the illness, there's very little that's different from all the other respiratory viral illnesses that we usually present with, right? You get the generalized malaise, body aches and pains, the fever. A lot of it is very simple. The one thing I noticed different with all patients who develop COVID is that the start of the infection is usually unusual. It didn't start with a sore throat, or it didn't start the usual way an infection starts. It usually starts, patients report they had a headache for a day, which was unusual, you know, or they felt very tired for a day, which was unusual. And then the other infective symptoms started. So I tend to question patients as to when and how the illness started to see whether it's the usual flu, whether there was something a little unusual about this. That draws my attention to it being COVID. The second thing is I've mentioned from the start, Philip, the eighth day and the changes that occur on that day. And I've seen those changes occur critically, even in the mildest of cases. It happened to me twice, Philip. I had very mild inflammation. I thought I was getting better. Exactly on the eighth day, almost to the hour, I had new symptoms emerge. Those new symptoms, I as a doctor, ignored them. The first time, the only thing that happened was I lost my smell and taste. I was improving, but I lost my smell and taste. I ignored it, and the following day it had triggered microvascular clotting that had me in ICU, luckily just for a day. The second time round, exactly on the eighth day, I was feeling reasonably fine. I had a trip down to the local mall, and the only symptom I had was for a few seconds intermittently, I kept getting cross eyed. And I got home that evening. That was my eighth day. I again ignored it. And the following day, I was in ICU. So, and that took me 4 days to get out of that. And both occasions, it was microvascular coagulopathy, and on both occasions, the only test that showed an increase was my D dimer. Now, in this last episode, they ran every test in the book, and everything came out clear. It was only my D dimer went up. It went up from 490 odd to 6,000. And I can guarantee you that rise started on that Sunday when I became cross eyed. The
You know,
Saturday before was fine.
I'm thinking to myself now because, as I said, I've always said that that microvascular clotting, the microclots that we said, is more like a vasculitis. It's an
Yeah.
inflammation in the blood vessel, which then leads to the clotting. And generally, when we think of severe COVID, and that's what you use, you bring in steroids and you have the extra thing of
Yeah.
antihistamine because you need to shut down the immune system. That's the beginning of the cytokine storm.
Yeah.
Now that the world has been either infected or vaccinated, I think that the presentation is different. It's not
Yeah.
quite the same. And I think that makes it very complicated because I've been listening to patients for a while, and what I have found clinically is that especially when their presentation doesn't add up, I start looking for a prodrome where they were unwell, just like you said, they were a bit fatigued, weren't quite right. And I look for that, and it oftentimes is a range of about 4 weeks, 2 to 4 weeks before their presentation that you tend to have that. Your presentation with the eighth day, I think that was more unusual,
Acute. Yeah. And
more acute.
I think when you have a patient who suddenly deteriorates, like I did, right? A healthy patient who's had no comorbidities, had no history of illness, and you suddenly have a patient where that happens. Uh, your first consideration should be is and if there's a history of a previous or a recent respiratory infection or some kind of infection, your immediate look should be towards this being COVID. Is it a reaction that this patient is having? Remember, if it is anything else, you have time. You have time. But time isn't on your side if this is an acute presentation like it did with me. If on that day that I started to notice I was cross eyed, if I drove straight to the lab and did my D dimer, because it happened the first time that it was a coagulopathy problem, I would have noticed an increase and taken immediate steps to negate it. So, when you talk about the vaccine, uh, COVID infections, and autoimmunity, what I think is happening is that either COVID infection or the vaccine primes certain tissue in the body because we're not sure exactly in which tissue. We know that spike proteins made throughout the body, but we're not sure in which tissue it's being expressed as a receptor. So, dependent on genetics, you might have different populations express it as a receptor in different tissues. And when exposed to the infection, present with an autoimmune response directed at specific targeted systems. Now, I know mine is my blood, it's my red blood cells. So, on the eighth day, it triggers an immune response that causes the clotting. And remember, at this point in time, Philip, why I say that. When this happened, I was on hydroxychloroquine and zinc through that first week. I was on antihistamines. I was on Ecotrin and colchicine. I took the necessary precautions, right? On that eighth day, the symptoms started anyway. I could not prevent it. And the only thing that saved my life was heparin. Now, when I look at it, it was going to be heparin if we caught it immediately. If the microvascular clotting proceeded to a point where it depleted my platelets, then heparin would have caused hemorrhaging, and we would have had to move to drugs like rivaroxaban that don't have the side effect of causing that kind of clotting. So there's a methodology to look at it. And I think we're going to have to find ways of classifying patients because some present with respiratory symptoms, some present with gastrointestinal symptoms. But I think there's a target because these patients, even when I get them well, when they have another episode, maybe 6 months down the line, they go down that same road with the same symptoms. Like I, on two occasions, had blood issues. Patients tend to, some have respiratory issues, some have gut issues, some have neuropathy.
Mm.
But I think it's to have a healthy suspicion and an understanding of the uniqueness of each patient and how they're going to present. And a lot of the time, I I look laterally. I mean, I have a patient, I've had a locum working, who's been treated in the past week and a half to two, twice for respiratory infections. He's had a chronic cough now for about 3 months. Uh, the respiratory infection was there. You could clearly see that in the first course of antibiotics. When he returned a week later, feeling better but still with the cough, he was given a second course of antibiotics. He came and saw me yesterday. He's not wheezing, yet he's being treated as an asthmatic. He has no sign of infection, but he has this chronic cough. Now, when I look at those kind of patients, the two things that seem to persist with COVID is either a chronic allergic process, or however triggered by autoimmunity, by hypersensitivity, by whatever triggered it, there is an inappropriate immune response. And the second thing is microvascular coagulopathy. And both can present in very much the same way uh, with respiratory symptoms, with gut issues, and that kind of thing. So when he came to see me today, his X-ray showed really nothing remarkable, which I'd sent him for yesterday. A very mild, consider bronchitis, which can be inflammatory. And so I did his D-dimer and interleukin 6 today. If I find either of those high, I think I know where to treat him, either as an allergic patient or a patient who's sitting with microvascular coagulopathy. A very mild microvascular coagulopathy, that's not enough to give him severe acute symptoms, but to cause persistent problems and probably in the long run lead to lung fibrosis that nobody seems to understand why it happened. So I think it's,
Yeah,
yeah, the individual,
it's one of the things that I think I'm concerned about is the fact that this is, I think that people are scared when it's acute. Okay. So, meaning that when things happen and somebody just suddenly gets unwell and in a few days they're on intensive care, that sounds scary. But if that person is unwell for 4 weeks and then they gradually get more unwell and then they die, people don't seem that concerned. They're
yeah,
okay with that. It's
that's
the same numbers, it's just the time frame is
yeah. You
different.
see, I think you're absolutely right there, Philip. And I think we need to humble ourselves as doctors, if because of COVID, right, and because of understanding the importance of time frame and solving the problem. The patient knows what he felt like before he got sick. My aim is to get him back to that state of health, right? So, whenever I treat a patient, I give them a clear picture of my expectation to their recovery. And I make it very clear that I'm not afraid to fail. And I'd like to know if I do. So when I have a patient who I'm suspicious of clotting, and I know it'll take 2 or 3 days to see some good clinical benefit, I tell the patient that in the next 2 or 3 days, I expect you to see a good clinical improvement. And if we give it a 2 or 3 days more and you're still not improving, come back. Come back. I need to look elsewhere. You understand what I mean? So I
Mhm.
don't mind giving the patient a clear understanding that if we're on the right journey, we'll see improvement. If we're not, don't leave it for another 3 months before you decide to address it. We need to
So,
get you back to good health quickly enough.
so I'm going to take you outside of that environment now, Shankar, and I'm going to imagine that I plonk you in a different environment. I'm dropping you now, not in South Africa. I'll drop you in the US, for
Yeah.
example. Okay. The most of the Western world operates by protocols.
Yep.
So they have these protocols that you have to follow in order to treat a patient. And usually every hospital and the system will come up with a protocol. One of the problems here is that I think it's an issue. I think that not just the general public, but I think clinicians are thinking that COVID is over. This is, we're having a few remnant issues. They are not anticipating another wave. Okay. Let's just suppose, as Gert had been talking about, a variant comes along. The variant is not as sensitive to the PCR. So people are not testing positive, but they are presenting with lung disease. Therefore, the standard approach is maybe it's heart failure, maybe it's just a chest infection. You're using antibiotics and you're using diuretics, but critically, you're not using steroids. So the clinical part, the management part is very different. So it is very important to know the difference.
Yep.
What happens in that situation? What could you do in that situation?
Well, I guess it's what could you do and what would you do? Uh, what I could do and what I would do is different things, Philip. What I would do is consider COVID, do the necessary testing, and treat that patient the way I'd see appropriately. The high dose steroids if I require. There's a study that came out in Japan recently, Philip, that showed that the H1 receptor is a very strong receptor for SARS-CoV virus, COVID-2 virus. Uh, so, yeah, from the start, I've been talking about this.
Mhm.
Antihistamines, the H1, H2 receptors, they all have been proven to be true. So yeah, if I had latitude, then I would look to all those different things and I would treat the patient accordingly. But of course, with being protocol driven, that puts me at risk of being litigated against for doing something outside that box. And I think that's what ties Western doctors' hands behind their back, that they're protocol driven. So you'd rather have a patient demise, even though you followed protocol. So you
No,
have no
this is this is
deviations or
this is a
stepping outside the
very
box.
this is an important point, and nobody talks about it. So apologize to clinicians for talking about the dirty laundry. But
Yep.
here is the reality: patients don't know this. But in the context of protocol-driven medicine, which is there for safety of patients. That's the truth. That's why it's there to standardize therapy. It's not designed for a pandemic situation where you have strange things happening. But the reality is that as a clinician in that environment, you are better off, you are safer to let the patient die than to try outside the box to treat them. What is your
Yeah.
thought on that?
I think, Philip, it shouldn't be called a protocol. It should be called a framework. So every patient is unique in the symptoms that they present with. Even a patient that presents with a simple thing like a urinary tract infection. Some have burning, some don't. Some have severe smell to their urine and cloudiness, some don't. So when I put the medication together, I know what is needed to treat a UTI, but I know what is unnecessary also. I don't need to give them the whole box of medication. So I think that you need that individualization of treatment with that patient. The problem is that when you do that, then you open yourself up to a whole lot of litigation. And I don't think that people understand the impact of such litigation and how it ties clinicians' hands. Remember, I have a lot of patients who sign living wills with me. I have a lot of patients who are organ donors. But the first thing I do when we go down that road with a living will and an organ donor is to explain to the patient that this is something that needs to urgently be discussed with the extended family so that when that time comes, we don't have a problem. Because it's only after the patient demises that the family wants to sue you because they feel you didn't do what's right. But the patient was there saying, do whatever you want. I want to survive. But the family weren't there when he said that. So I got that. I think patients need to take far more responsibility for the choices they make and for whose hands they choose to put their lives into. And of course, they need to understand that yes, we might be doctors. Uh, all of us treat patients differently. I can almost guarantee you, Philip, that the same patient won't get treated the same way by two different doctors. We cooks.
Yeah.
We don't do it the same way. So protocols go against that, and that's why I say a protocol should be a general framework for a doctor to use. It shouldn't
So
be something to litigate against if
yeah,
it's
so
not.
it brings the issue though, is that within the protocols, and this is a question, so I don't know if any clinicians are listening, but it is a really important question. If we have a situation where there is a variant that is not as easily detected, or let's say it's 80% effective, the PCR test, 20% of people are going to have COVID and not have a positive test. Okay. So
Yeah,
that 20% of people who present with respiratory compromise, who are unwell, who are not responding to antibiotics, how do we diagnose if it's COVID and they need immune suppression? That's the question.
yeah, and that's something I've been pushing from day one. I did speak about a spike-specific IgE test to look for titers, which might show up on the eighth day. We might look for certain types of antibody immunoglobulin responses that we can look for. That would because remember, Philip, when you're treating a patient 3 weeks down the line, the virus has long left. So looking for COVID is of no consequence. We need to know what's going on with the patient to treat it. We know what COVID leaves behind. It leaves behind an inappropriate immune response. It leaves behind microvascular coagulopathy. We know what it leaves behind. So we got to go looking for those kind of things to try and fix that kind of problem. Now, when you talk about 80%, yes, I was always taught that you never use a test to come to a diagnosis. You always use a test to confirm your diagnosis. So in those 20%, the test being negative doesn't tell you they don't have COVID. It just tells you the test was negative. I would say a positive test, I would believe. A negative test, I treat with suspicion. I'd prefer to trust my clinical judgment over the fallibility of a test.
So it raises a question now, and I'm talking about, I guess, some clinical observations. My rule of thumb is that the it needs to look like a duck and quack like a duck. So if I see a patient with chest symptoms, that should be a chest infection, but their CRP, the inflammatory marker, instead of it being 200, is 400. That's a red flag for me.
Yeah,
If the CRP is very elevated and I don't see typical patterns
clinical
of,
picture. Yeah,
then I'm worried.
yeah,
The other thing that I am thinking about is that I believe that when you don't know, you investigate more. And one of the tests that I think needs to be done, therefore, very early is a scan of the chest, a CT scan, looking for ground glass changes, because that kind of inflammatory change doesn't suggest a typical infection.
yeah.
And so if you are
And I
then,
think as well, Philip,
Mhm.
for clinicians to realize a ground glass appearance does not diagnose pneumonia.
Yes.
You know what I mean? If I give you a scenario, I kept at the beginning of the pandemic sending patients for X-rays, and it came back saying ground glass appearance, COVID pneumonia, right? And it irritated me because they kept using the word pneumonia, and this was not an infection. So when I started sending patients for X-rays, I wrote on the request form, query hypersensitivity pneumonitis. Then I started getting X-rays coming back to me from the local radiologist to say ground glass appearance uh, confirmed clinically between pneumonia or pneumonitis. He then, when he saw my work, went ahead and started giving lectures to other pathologists in the area and radiologists in the area that ground glass appearance is not a diagnosis of a pneumonia. It is a differential diagnosis, and they should consider hypersensitivity pneumonitis. Then I started getting x-rays back saying hypersensitivity pneumonitis.
But
So these
it
are the little
raises
nuances we need to be, aware of.
yeah, absolutely. But this is why I'm asking a genuine clinical question here, because the system is so weighted towards the PCR test,
Yeah,
for which I am worried either is not as effective as it should be, or could become even less effective with new variants, because you can't guarantee that the LB1 is going to respond in the same way as the previous variant. So
yeah, yeah,
in that circumstance, what we need for clinicians is a framework where they can say, okay, if you find that there is nothing obvious on the chest x-ray, or even just diffuse bilateral non-specific changes with an exceptionally high CRP and maybe very high
yeah,
oxygen requirements, combined with an elevated D dimer over,
yeah, 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 yeah,
this is what I mean, is that
yeah, yeah.
the
You're right.
other
You're
thing.
absolutely right there, Philip. I've
Mm,
had patients who have suffered with either long vaccine symptoms or long COVID symptoms for periods of 2 years, where they've had every test in the book, seen a cardiologist, seen a neurologist, everything. They come to me 2 years later with all these results, but not a single one of those doctors has done a CRP, interleukin, or a D dimer. And when they see me, those are the three tests I do. And invariably, one of them is high. Now, how come you've run, same with myself, how come you've run all these tests and they're negative, but just one or two are high? So, how hard is it to harbor a healthy suspicion in a patient who's been unwell for more than 10 days and you are failing to, or a patient, more importantly, that seemed to be improving and suddenly started to worsen and then refuses to improve, where dependent on whether that worsening was acute and needed critical care or it was just a slight worsening that refuses to improve, harbor a healthy suspicion that this might be a COVID reaction and do those three tests. And sometimes when I am in two minds, I'll do those three tests with a full blood count to rule out infection. Because if I'm going to put a patient on a steroid, if there's an infection, I'd like an antibiotic coverage.
mm.
So sometimes if the patient might have had a fever, I'm suspicious there might be an infection, I do a full blood count with those three tests just to look at do they have elevated leukocytes, those kind of things. So why are we running all angiograms and CT scans and the rest when we've got three tests, CRP, interleukin, and D dimers, and with a full blood count will give us a good understanding of what we're dealing with and at least advise us on where to start. The rest can.
It's difficult times ahead because, as I said, I don't think the medical fraternity is prepared enough for the complexities of the questions that are coming. And as I said, that when you add on top of it that there is a delayed response
Yep.
for many patients, and the patients don't even remember that they had this flu-like illness for which they never tested for 4 weeks ago, but they're coming with just strange,
Yeah.
oftentimes these days, neurological symptoms. It just doesn't add up. And if we don't have the ability to know how to identify who will benefit from immune suppression, the
Philip,
outcomes are like
yeah,
it's a huge, it's a nightmare.
yeah. But Philip, if I had to consider my treatment for the microvascular clotting and my treatment for the inappropriate immune response, right? Uh, Prednisone, fair enough. You got to have a clinician to rule out infection and use it in the right situation. So, fair enough. You got to look at the patient and make sure you're not going to. That's the one medication that can cause problems if you got a patient with an infection and you didn't cover them with an antibiotic. But the rest of it, antihistamines, H1 blockers, H2 blockers, your cimetidine, ranitidine, famotidine, right? Your Icotrin, your aspirin, your colchicine to cover it, because we found the combination of aspirin and colchicine tend to work with the microvascular clots. Now, all those medications are generally over the counter tend to have very few side effects, if any, and if any side effects can be withdrawn immediately and those side effects are reversible, but will show very quick clinical benefit if you're on the right track. Why aren't we trying it? You've got a patient sitting for 1 year with symptoms. You can give them medication that's over the counter and within 2 days notice a benefit. I'm not asking you to treat them for 6 months. All I'm asking you to do is give them a week of treatment and see if it has any improvement. And I tell this to patients. I say, look, I'm putting you on this. It's my standard of care when it comes to treating this. After a week, you might find 10 of your 12 symptoms have subsided. The other two come back. Let's have a look. There might be long term injury, there might be pre existing conditions that were undiagnosed, all that kind of thing. So I think it's to be open with the patient. But remember that treatment poses no harm to the patient. So why not try it? My only question to the patient is, are you allergic? The next question is, do you have sedation with antihistamines? Then I know my latitudes in how I can treat you. Do you know that phenergan, promethazine, a specific H1 blocker, is one of the most effective medications I've ever used in COVID? And I mentioned this to you many times, Philip. For the
Mhm.
last 2 months, I can't find stock of it. Do you know that when I mentioned phenergan in the first wave, the World Health Organization put a red box warning on it? There was never a red box warning, and phenergan has always been an essential medication, a life saving medication that every doctor should have in his toolbox. Then I went on to mention Montelukast. And for about 2 weeks, there was a red box warning on the World Health Organization site about Montelukast. So now I keep thinking to myself every time I find a solution, the pharmaceutical industry seems to have a hand in making it unavailable.
Mm.
So there's a lot going on, more than meets the eye, that's going on in the background. So I think, yeah, clinicians need to understand that. I've always been called a doctor, Philip, that uses medications from Noah's Ark. But let me tell you, I trusted the ethics of the pharmaceutical fraternity, I'd say, around the 80s and the 90s. But I saw clearly around the mid 80s to early 90s the problems that crept in, the commercial interests, the lack of scientific rigor in the way they tested medication. And so any medication that's come out, say, after 1990, I'm very cautious about ever using it. I'll use it as a last resort when everything else failed. So I get classified as this doctor who uses medications from Noah's Ark when there's supposedly better stuff out there. But hey, it's Noah's Ark that got me here, so hey, call me what you wish. I prefer to use something I know was ethically made, and I know the tools I have. I
Brilliant,
trust it.
brilliant. Yeah, Shankar. So yeah, so this I think is going to be an ongoing discussion. Just in case our audience is listening, we're only keeping it for short periods of time. But I think that as we continue to see an evolution of disease, and this is what I think is going to be happening, is that it would be great if we could find that everything disappears and life gets back to normal.
Yeah.
That's not my expectation, but I don't mind. It would be great. And
Yeah.
so we represent here the questioning minds who are looking at symptoms, analyzing it, trying to find solutions, and critically, especially for clinicians who are in first world countries tied by protocols that are not necessarily as effective, the hope is that just by thinking, we can find solutions that are available to patients, help patients to make their own choices.
Yeah.
If you can't prescribe it, you say use this or use that, and give them the leeway to try and make a difference for their health, because the system, I think, is now like the Titanic. An
Yeah.
iceberg is in front of us. No matter how hard it tries to turn, it is too big, it is too slow, it's going to hit. You need the lifeboats, and that's what the thinking
And I
clinician.
think as well, Philip, if you look at the timeline, the from the 90s when the scientific rigor, the commercial interests became part of the pharmaceutical industry, all those kind of things happened. It was at that point in time that the litigation against doctors increased. And now we're
Mm,
sitting with that problem. So we got to find some balance between the two. The litigation ties my hands, and the pharmaceutical industry dictates what I can and can't give you. So There's the circle, there's a ring of fire there that needs to be broken.
Absolutely, absolutely. So, yes, wonderful. Thank you again, Shankara. And we'll have another conversation, I'm sure, again soon. And audience, look out for these. These are clinical insights into analyzing, understanding COVID with one of the best in the world, Dr. Shankara Chetty. So, thanks,
Thank you.
Shankara. Just hang with me. And for the audience, have a great evening.